presentation will be considerations when submitting proposed excipient levels in inactive ingredient control correspondences, and that will be delivered by Dr. Zakia Williams-Greene, followed by Dr. Pamela Dorsey. Oh, I keep forgetting. Dr. Zakia Williams-Greene is a senior pharmacologist with the Division of Bioequivalence I within the Office of Bioequivalence at the Office of Generic Drugs. Following that would be Dr. Pamela Dorsey, also a senior pharmacologist, this time a Division of Bioequivalence III within the Office of Bioequivalence at OGD. Then we'll have Dr. Quinn Liu, Deputy Director of the Division of Bioequivalence I, and also Dr. Julia Yang, pharmacologist with the Division of Pharmacology, Toxicology Review in the Office of Safety and Clinical Evaluation at OGD. So these are our speakers for the next session. Let's introduce and welcome our first speaker, Dr. Zakia Williams-Greene.
Thank you, Brenda. Good afternoon, everyone. So the title of my presentation is Considerations when Submitting Proposed Excipient Levels and Inactive Ingredient Controlled Correspondence. I am your presenter, Dr. Zakia Williams-Greene. So this is my disclaimer slide. I'll slip right past it to get going. What is our learning objective today? It's to encourage focused correspondence per the dosing guidelines provided in the reference listed drug labeling. In particular, is to explain how maximum daily exposure, MDE, levels are evaluated according to the respective maximum daily dose, MDD, when based on the requested patient's age and/or weight. So evaluating proposed MDE excipient levels often presents a nuanced challenge, and that is because comprehensive assessments of MDDs are based on various factors: patient age, body surface area, weight, one of them, two of them, sometimes all three of them. So I have some case studies I'll show. Inactive ingredient control correspondences and inquiries for proposed MDE levels should align with fundamentally these two things. There are other things, but fundamentally these two things: the reference listed drug labeling dosing instructions across all patient populations, and the recommended 3 evaluation limit, and the controlled correspondence related to generic drug development guidance for industry. I will refer to that as the CC guidance. So here's a snapshot of that area in the CC guidance, and this is referring to requests related to inactive ingredients. Take note that I have highlighted and circled one of the most important parts of this section and then the guidance, and I'll read it in verbatim. FDA recommends that a requester submit for evaluation no more than 3 inactive ingredients and no more than 3 proposed levels for a drug product in any given controlled correspondence. So anything beyond that still has to go abide by that 3 limit evaluation criteria. The following case studies are just simply examples, but they are real scenarios. All the numbers are hypotheticals. Nothing here are actually real numbers, but they're based off of real case studies that I've evaluated. So example case study number 1. Prospective applicant Z inquired about 3 proposed MDE levels in the pediatric population with a body weight of 1 kilogram to less than 7 kilograms. The applicant's proposed MDE levels were based on an MDD of 6 units. Hereforth, I will refer to the prospective applicant as simply as applicant. What does the label say? It's the first thing we do every time. So per the reference listed drug labeling, the MDD for this drug product varies according to 4 different weight ranges. 1 kilogram to less than 3 kilogram, body weight is 2 units per day, 3 to less than 5 is 4 units, 5 to less than 7 is 6 units, and 7 kilograms and heavier is 8 units per day. So there are 4 different MDDs per the RLD labeling. What did we do when we evaluated this IIG CC inquiry? Evaluations of MDE levels were conducted according to the MDD used by the applicant, which corresponds in this case to pediatrics weighing 5 kilograms to less than 7 kilograms. We found, for the sake of efficiency, instead of sending a clarification back to the applicant saying, hey, listen, the labeling for this wide range from 1 to 7 has 4 MDDs. Can you specify which one? Instead, we simply will evaluate the evaluation based on the MDD submitted by the applicant if it's in corresponding with the RLD product, which in this case it was for 6 units, but we will specify which evaluation we do. And in this case, it's 5 kilograms to less than 7 kilograms. And we will communicate that to the applicant. So in the response to the request, there's pretty much the same approach in which we inform the applicant what the labeling says for the corresponding RLD. We let them know what we did with respect to their inquiry for the MDE levels evaluation. We'll tell them what we actually did versus what they've asked. And then we'll always welcome additional CC inquiries if they have. So in this case, we will say to the applicant, as stated in the RLD labeling, there are 4 distinct MDDs based on various weights across the patient population. Acceptability of your MDE levels were evaluated using the MDD you considered, which is 6 units, which corresponds to a pediatric population of 5 kilograms to less than 7 kilograms. Evaluation of MDE levels as requested, 1 kilogram to less than 7 kilograms, would require evaluations for each distinct weight range and exceed the evaluation limit of 3 as recommended in the control correspondence. So we pretty much explained to the applicant why we did not evaluate the entire weight range as they presented it. And lastly, for evaluations in other weight ranges, please submit a CC inquiry for the respective patient population based on the corresponding MDD per the RLD labeling. We'll always note a caveat, basically, the acceptability of excipient levels for all patient populations will be evaluated during scientific assessment of the ANDA. Case study number 2. Applicant A proposed an MDE level for each of 3 different excipients, so that's their 3 evaluation, and pediatric patients, infants and children up to 3 years of age or 13 kilograms of body weight. They also proposed an MDE level based specifically on patients weighing 13 kilograms. What does the label say? Dosing is based on weight in this case. Therefore, the MDD varies. Mind you, they specify a weight of 13 kilograms. What did we do? We evaluated the MDE levels based specifically on the pediatric population for this weight because that's what the applicant specified. In our response, we would state the labeling, reference listed drug labeling for MDD, which varies according to weight. We also informed the applicant that acceptabilities of their proposed MDE levels were evaluated considering the weight that they chose, which is 13 kilograms. And we informed them that evaluations were not conducted considering the weight for the youngest patients, which in this case were infants. We also informed the applicant that evaluations of MDE levels as requested, infants and children up to 3 years of age or 13 kilograms body weight would include patients as young as infants, and patients up to 3 years old, and it would exceed the evaluation limit as 3 as recommended in the CC guidance. And lastly, for evaluations of MDE levels in any other patient group, that would be patients weighing less than 13 kilograms, they're welcome to submit an additional inquiry. Number 3, case study number 3. Applicant Y inquired about 3 proposed MDE levels, specifically for pediatrics age 6 months to less than 7 years. The applicant proposed MDE levels considering an MDD of 222 milligrams. Consistency, what did the label say? The label says there are 2 recommended MDDs for children 6 months to less than 7 years. So in this case, it's not based on weight. The previous example was based on weight. This is based on age. There are 2 MDDs, and the MDD is actually specified in the label. For children 6 months to 12 months old, the MDD is 111 milligrams. For children 13 months to less than 7 years old, the MDD is 222 milligrams. So our evaluations were conducted considering the MDD used by the applicant, which was 222 milligrams, and that corresponded to the children in the older age group, 13 months to less than 7 years. In our response, we informed the applicant that there are 2 recommended MDDs for children from 6 months to less than 7 years. Acceptability of their proposed MDE levels were evaluated using the MDD that they considered, 222 milligrams, which corresponds to that older age group, 13 months to less than 7 years. We also informed them that evaluations were not conducted for 6 months, for patients 6 months to 12 months old, which corresponds to a different MDD. It corresponds to a different MDD, would calculate a different MDE. Therefore, evaluation of MDE levels as requested from 6 months to 7 years would exceed the evaluation limit of 3 as recommended in the CC guidance. For evaluations of MDE levels for that lower patient population, 6 months to 12 months, they would we invite them to submit an additional inquiry. So case study 4 and 5, I tried to capture all of the previous examples. So this one's a little convoluted, but they got it right. This one's a little complicated. Applicant D stated its intent to develop a drug product for a specific indication and inquired about MDE levels in pediatric patients 5 months old. So that's what their inquiry is. However, their proposed MDE levels were based on an MDD corresponding to a different indication and using a weight for patients that are 10 years old. Per the label, this product has 2 strengths, each with a distinct indication tied to a specific patient population. Dosing for both strengths is weight-based and have different MDDs. For the lower strength has multiple weight-based daily doses for patients 5 months to less than 5 years. And the higher strength has multiple weight-based daily doses, but for patients 5 months to 10 years old. And in this case, since the applicant specified its indication and that they were inquiring about patients that were 5 months, it required us to recalculate their MDD based on their proposed per unit levels. So MDE levels were recalculated using the proposed per unit levels and the MDD for the lower strength in patients that were 5 months old, which has a different weight of 10 years old, based on the indication and age range that the applicant specified in their inquiry. When we communicated to the applicant, we stated that the reference listed drug, per the reference listed drug, RLD labeling, there are 2 strengths, each with a distinct indication for specific patient population. The reference also lists different MDDs based on various weights for the respective strengths. Thus, although you stated your intent to develop the lower strength in patients 5 months old, your proposed MDE levels were based on the MDD for the higher strength and a weight for patients at 10 years old. Given that the MDE levels were evaluated using the proposed per unit amounts, considering the patients of 5 months old and corresponding to the MDD for the lower strength. This is what we communicated to the applicant. And lastly, this tries to capture all previous 4 examples, and these are just a snippet of all the various examples, case studies that we actually have. Applicant A inquired about proposed MDE levels for an excipient in 3 different strengths, the 5 milligram strength, 20 milligram strength, and 40 milligram strength, specifically for the following pediatric population: 3 months to less than 6 months, 6 months to less than 8 months, and 8 months to less than 10 months. Per the reference listed drug labeling, the MDD is strength dependent and is based on both age and various body weights. So for the patients that are 3 months to less than 6 months, the MDD is 1 unit of the 5 milligram strength, and these patients are weighing less than 5 kilograms. For patients 6 months to 8 months, the MDD is 1 unit of the 20 milligram strength, patients weighing greater than 10 kilograms. And for patients 8 months to 10 months, the MDD is 2 units of the 40 milligram strength for patients weighing 15 kilograms. So it's pretty convoluted, and it captures all the other 4 examples. And the sponsor got it right. This was a relief. Evaluations was conducted on the proposed MDE levels as submitted. Levels were accurately calculated by the prospective applicant according to the age, body weight, and the respective dosage strength. Given that, We communicated to them that per the RLD labeling, you calculated your proposed MDE levels in accordance with the dosing instruction for the RLD product labeling, and according to their respective strengths. Based on OGD evaluation, your proposed MDE level, in this case, their proposed MDE level, the MDE levels do not exceed the limit for the same inactive ingredient in previous FDA-approved drug products for the same route of administration and context of use. So key takeaway, if a specified patient population is queried and the drug product MDD varies on age and weight, please calculate the MDD according to the weight or age that correspond to the queried patient population. Additionally, the proposed MDE levels will be evaluated for the specified patient population according to the corresponding weight or age. Know that evaluation of the proposed MDE levels will be based on the MDD by the applicant, and that MDE levels will be recalculated if calculations are not aligned with the recommended MDD per the RLD labeling. And equally important, if not most important, the number of MDE level evaluations will not exceed 3. So here's my challenge question. The MDD calculated by the applicant based on patients with varying weights should A, cover the entire patient population, B, be calculated for any weight, or C, be specific to a weight or weight range that corresponds to an MDE evaluation limit of 3. Ding, ding, ding. Show of hands. A. Okay, B. C. Every hand in the, this is wonderful. Thank you. So C, you all are all correct. So my closing thoughts, and I have a few minutes. When you calculate proposed MDE levels according to the reference listed drug labeling, please know that this will help us answer your query most efficiently. You'll likely not receive an additional response asking us to send you another inquiry. And we support your generic drug development and market drug development for the market. So thank you very much. This ends my presentation. I will, one thing, I did not have a thank you slide because I was concerned about running out of time. So I'd like to thank my deputy director who helped me much with this, Ching Liu, Paul Munchie, and everyone who helped me with this presentation. I am now welcoming Dr. Pamela Dorsey. Thank you.